Okay, here we go. Let's do some more. Now we're going to start with the reproductive system. So this week we're going to look at female-male reproductive disorders and breast disorders. So, and I will break this down into 3 separate sections. So we're going to start first with chapter 58, which are the female reproductive disorders. So again, like I always start with, make sure that you know your anatomy. If you don't understand anatomy, the rest of this stuff is not even going to make sense. So this should all be standard. I'm sure you have this in anatomy and physiology. A couple things I just want to point out. Fallopian tubes, you got your ovaries here, produces the eggs. Women are born with all the eggs they're going to have. There are about 40,000 of them. The egg is released into the fallopian tube. Down this is the uterus. And now keep this in mind. This is the uterus. So when we do a hysterectomy or a salpingo-oophorectomy, meaning a total hysterectomy, we're going to take the entire uterus out, and the fallopian tubes and the ovaries. That's a total abdominal oophorectomy. But you'll notice that the vagina still stays. We don't take out the vagina when we do a hysterectomy. A lot of students get that confused. A female can still have sexual intercourse because you have sex in the vagina, you carry babies in the uterus. That's important to remember. The next thing I wanted to point out, this is obviously a medial cut here. The rectum comes out here, the uterus is here where the little baby is born, vagina is up in here, and this part is the bladder, and this is the urethra. So the urethra opening is right here, vaginal opening is here, rectal anus opening is here. So when your patient develops fistulas or rectocele or cystocele, meaning prolapse of these organs, because the muscles that control the like bladder and incontinence, like we were talking about during renal week, is right here. So women that have had a lot of babies, it grows up in here, gets big, then they birth the baby. All of this stuff gets stretched out. If they have diverticulitis or Crohn's disease, they can start developing fistulas this way, and so you can get fecal matter into the vaginal canal, and you get fistulas this way, you get urine into the vaginal canal. So this is important to remember because a lot of disorders occur right in here, and those are some things that we're going to talk about. There's a lot of stuff that can go wrong in the female reproductive system, but the ones that we're going to focus on are the vaginal infections, very common, that's why we're going to focus on that. Pelvic inflammatory disease and endometriosis, again, very common. Some of the tumors, some of them are benign, others are more malignant, and then some of the structural disorders that can occur. So let's just jump right in. I'm sorry this is a little bit not complicated, but busy, a little bit of a busy slide, but these are really important to know. The reason that the vaginal infections are important to know is because they're very, very common. These are very common in women. One of the most common are the yeast infections. As you know, yeast loves dark, moist areas, and the female perianal genital area is classic warm, moist area. So most women will have at least one yeast infection in their lifetime. It will present as it looks like cottage cheese. Is what it looks like. It looks like the vagina is producing cottage cheese. It's extremely itchy, very uncomfortable for a female. Good news is, if you identify it early, it's easily treated. Women can get over-the-counter medication. Any yeast medication will work. Monostat is a classic one you probably already heard of. Usually it's a 3-day application. It's a cream. It gets kind of inserted like sort of like a tampon kind of thing. You have this cream in there. Usually the symptoms start going away. The official name for it is Candida albicans. It's basically a yeast infection. Super common. You need to know if your patient comes in and they start saying, my vagina is really, really itchy. I've got this discharge. You ask them what it looks like. It looks like white cottage cheese. Yeast infection. send them to the drugstore, they can get monostat on their own. The other thing that we worry about is our patients who develop STDs, sexually transmitted diseases. Again, from a nursing standpoint, very, very important that we're educating women on preventing the spread of the disease and preventing them from getting the disease. So most of the STDs, most of the sexually transmitted diseases are bacterial. Like the gonorrhea is a bacterial infection. The thing here is to identify it early and then treat it, and for sure teach your female patient to absolutely not have intercourse while they are still infected, because that's how these STDs get spread. So the gonococcus is typically presenting more with a yellow, purulent kind of discharge. It's going to look a little bit more like mucus kind of thing. Again, you're going to want to identify it, get the patient on antibiotics. Absolutely no sexual intercourse. It's for sure not like unprotected sexual intercourse. Trichomonas vaginalis, this is another one of the STDs. And again, it's you're going to have a little bit more of like a foamy, white, foul smelling discharge. This is usually a classic symptom that somebody has some kind of vaginitis, is when they start developing some kind of discharge that's not supposed to be there. The female reproductive system should be moist, but should not have like some kind of a discharge coming out. If there is, there's a problem. And with the trichomonas, again, treated with antibiotics and prevent the spread, because you can easily spread it to other people. And again, Gardnerella vaginalis. This one is a watery, kind of a fishy smelling sort of discharge. Once again, you can treat it with antibiotics, but you need to identify it early. So most of your vaginal infections are either going to be a bacterial or a yeast infection. And that's most of the vaginal infections. Let's move on to pelvic inflammatory disease, also known as PID. Very, very common female reproductive problem. Again, they think that the pelvic inflammatory disease is caused by STDs. So this is a bacteria that either has gone unidentified or has not been treated properly. Gonorrhea, chlamydia from bacteria and the problem is it's traveled through the vagina now up into the cervix, and the cervix is the structure right before it gets to the uterus. Sometimes there's a kind of intrauterine device. It's called an IUD. It's like a little T like this that some women use for birth control, and it's inserted by a gynecologist or a physician. They insert it into the uterus and it just stays there. And the way that it works is that the brain thinks that there's already an egg implanted in the uterus, and so it won't allow another egg to get implanted in the uterus. And that's how it works to prevent birth control. However, sometimes that structure, that IUD that's in there, can cause pelvic inflammatory diseases. Now they're making some new ones. You might have seen now, like the O-ring. There's a commercial like, oh, the O-ring. I don't think that one has as much implications for pelvic inflammatory disease as some of the intrauterine devices. But the problem with pelvic inflammatory disease, it can affect all of the structures in the female reproductive system, and then what can happen is, because of the scarring and the rebuilding, it can start leading to adhesions and scar tissue. The problem with that is then it can lead to infertility because of the structure can start clamping down on the fallopian tubes. It can clamp down, cause some adhesions. Remember I showed you those pictures of like the bowel adhesions? That kind of those adhesions can start occurring in the uterus, outside the uterus, around the ovaries, around the fallopian tubes, and can cause either female infertility or sometimes cause an ectopic pregnancy. Hopefully you learn what an ectopic pregnancy is in OB. If not, let me know. I'll tell you what it is when we get to class, but I don't want to bore you if you already know what that is. So who gets pelvic inflammatory diseases? Women who have been highly sexually active, especially under the age of 25. And some reasons for that is they're higher risk for developing the STDs because they pass around these infections a lot more. STDs are very similar to a common cold. When somebody has a cold, then next thing you know, everybody has a cold because it spreads so easily. That's what happens in some of these STDs. So I already told you about those two reasons that people can actually they're at higher risk for developing PIDs. So how do you know that somebody actually is developing pelvic inflammatory disease? It's painful. It's usually quite a bit of diffuse pain in the pelvic region, very low abdomen, can have some tenderness. They can develop some foul-smelling vaginal discharge, especially if it's associated with a bacteria. If it gets bad enough, they can also have like general malaise and flu-like symptoms with fever, chills, nausea, vomiting, things like that. They might have some pain during sexual intercourse, especially depending on where exactly it is, especially if it's near the cervix area. But sometimes the symptoms are so mild it goes undiagnosed, and in other patients, if the symptoms are so severe that it's almost debilitating. So this is what some of these adhesions look like here. This is the uterus, and see how these adhesions, these really tight bands, and what it's doing is it's starting to pull those bands in. It's extremely painful. These are some more adhesions in here, and these women are obviously in surgery right now, and they're having to clip these bands just in order to help improve the symptoms of pelvic inflammatory disease. You can see all of the inflammation here. What was I going to tell you about this? I guess I already mentioned all of that kind of stuff. So, okay. So now let's talk a little bit about endometriosis. Endometriosis is endo being inside. So whereas pelvic inflammatory disease can occur, I thought I had a better picture of this. I'm going to show you a picture in class of, or you can Google it, of pelvic inflammatory disease versus endometriosis. So the endometriosis is, again, it's a problem during childbearing years. And what happens in endometriosis is that the endometrium is the inside lining of the uterus. So that's endometrium. Similar to the word like peritoneum, and it being the inside lining of the peritoneal cavity. So the endometrium is inside the uterus. The osis is inflammation of that. And what happens is the inside lining of the uterus now is in places that's outside of the uterus. However, it acts like pieces of uterus. And so it is very receptive to hormones, estrogen and stuff. So what happens is that as the normal cycle, the normal female cycle, where the estrogen and progesterone fall and drop, and it will, like when the estrogen, like the lining of the uterus gets thicker and thicker and thicker because it's waiting for a little fertilized egg so it can, do its thing and support a little baby. Well, then if there's no little baby there, then the inside lining of the uterus, the endometrium, sloughs off and the woman has her period. Well, the problem is when you have these pieces of the inside lining of the uterus that's outside of the uterus, it will respond the exact same way to the hormones. So the hormone levels adjust, and so when it's time for that uterus to slough off, these little pieces that are outside the uterus will do the same thing. It sloughs off and breaks away and bleeds, but there's no exit because they're in spots that is not like the vagina, so there's no place for it to go. And so you've got these little bleeding masses all over, pretty much in the abdominal and pelvic cavity, and it can become very painful. And it can create scar tissue and pain and other problems, and it's another big cause of infertility in women. So this is what it looks like. So this right in here, this is the uterus again. Right in here, this is the endometrium. Well, what happens, and this part sloughs off once a month if there's no little baby in there, sloughs off, bleeds and exits through the vagina, and the woman has her period. Well, what happens is you can get little pieces all up in here, and all of these little pieces will respond exactly the same way to the ebbs and flow of estrogen and progesterone, and then when they start sloughing off, there's nowhere for it to go, so it'll bleed like down in here, can bleed off it like into the vagina. This stuff like this makes intercourse very painful because it's right in here, the vaginal canal where intercourse occurs. So it's very, very difficult problem to treat. I already told you about like how it causes problems. I already told you about that. That it's painful and irritative, that it can form scar tissues, makes it very hard for a woman to get pregnant. But they're not really sure what causes it, so they're not really, the treatments for it aren't great. So sometimes, women who have higher levels of estrogen during their childbearing years, that's when it's worse for most women. Sometimes the gynecologist can adjust birth control to kind of keep their hormones a little bit more level so they don't have those normal ebbs and flows. That can help with some of the symptoms. Pain management is really helpful in these women. But once those estrogen levels stop, when women kind of hit their 40s and beyond, especially after menopause, then usually the symptoms go away. However, that's a long period of time to be uncomfortable. So these women are usually followed pretty closely by their gynecologist, and for us as nurses, you want to identify and treat symptoms, treat pain, use some of the estrogen, progesterone contraceptives, like I just told you, to keep those hormone levels consistent, so you don't have additional extrauterine bleeding. And the use of oral contraceptives is sometimes useful. And sometimes, if it's bad enough, and this really depends on if the woman doesn't want children or she's done having children, then they can do like a surgical menopause. And when you hear the word surgical menopause, that means that the patient has had their ovaries removed. And that will trigger menopause. So anytime a woman has had both of her ovaries taken out, she will go into menopause. So that's what is meant by a surgical menopause. So that's endometriosis. It's a horrible disease and a little bit difficult to treat, but really fairly common. Okay, so the uterus can also develop fibroid tumors. I recommend you guys looking at box 3310 in your text. Fibroid tumors are not malignant tumors, and the way that you can tell, for one reason, they just look like big massive balls, but they're not ugly. They're not like a cancerous thing that just looks bloody, purpley. I'm going to show you some pictures of that. Nonetheless, they can create a lot of problems. And they can grow anywhere. They can grow intramurally, and the uterus is a massive muscle. It is a huge muscle because it's got to push out a little baby through this little itty bitty hole. So this is a really big solid muscle. So you can get fibroid tumors intramuscularly. You can get it right on the lining of the outside lining of the uterus. You can get these big pendulum ones. These kind of are almost pendulous. Growing completely on the outside of the uterus. You can get them blocking the fallopian tubes. You can have them hanging down like into the cervix and even into the vaginal cavity. The problem is they're not malignant, so your patient is not going to die of a malignancy. However, they can absolutely cause infertility. So a woman who's trying to get pregnant, if the body perceives that there's already a baby there, it will not get pregnant. Or if it has all of these fibroids hanging down inside the uterus like that, it won't get pregnant. So, and this would just lead to very painful intercourse. So these can be treated surgically. So if a woman is of childbearing years and she still wants to have children, sometimes you have to go in and have these removed surgically. Women who have fibroid tumors often have very painful menstrual cycles, a lot of cramping, a lot of bloating, excessive bleeding. They bleed a lot because this causes a lot of sloughing. So again, if your patient presents with some of these, you would send them to the gynecologist. It's easy identified on a scope, and then and CAT scan would, like if you've got one up here, you're not going to see that on scope, obviously, but you can see that on CAT scan, and the patient can go in and have surgery and have those removed. The problem is when your patient goes in and has anything removed, then they're at higher risk for scar tissue and adhesions, and again, might not be able to get pregnant. That's one cause of female infertility. Sorry. I've been talking too long. Polycystic ovarian disease. This would remind you a little bit of polycystic kidney disease. We're not entirely sure why women get polycystic ovarian disease, but basically it's a bunch of cysts in the ovaries. These patients tend to have amenorrhea, meaning they don't have periods, or oligomenorrhea, like small little scant periods. And the problem is because every month a little egg pops out of the ovary and swims down the fallopian tube into the uterus. I'm dying here. Waiting to get fertilized. Well, when the cyst, the ovary is totally full of a bunch of cysts, they tend to not release eggs. So what happens is, and also the ovaries produce a ton of estrogen. So what happens when these aren't working, then one, the woman doesn't have periods or has scant little periods, oligomenorrhea, or they will start developing more male-like symptoms. So they gain weight, they can have start developing male baldness patterns, they can have higher lipid levels, they can have acne, they can have hypertension, weight gain, and these are also associated with some of the other endocrine disorders, such as like an overproduction or an inefficient use of insulin and high testosterone levels. So you might see a lot of glucose problems in your patient. So if your patient, and they could have the ovaries sit way down here low in the pelvis. So if they're having a lot of pain in that region, plus with these symptoms, might be time to get an ultrasound. This is an ultrasound of a polycystic ovary, and then again, depending on the woman and what they have going on, because again, it's between 20 and 40, and if this person has not yet had children and wants to have children, it can be a fairly debilitating disease. Let's talk about cervical cancer. The number one, 99% of the time, cervical cancer is caused by the human papillomavirus. So the human papilloma virus is a sexually transmitted virus. And for the longest time, we did not have any way to prevent this problem. Well, recently now, we have a vaccine that we can treat children with, and we recommend starting at the age of 13 for all females that they get the HPV vaccine. And it is a series of 3 vaccines over I think it's 6 months, might be 8 month period of time, where these young girls, and now they're even recommending it to boys, they get a vaccine that will prevent them from getting HPV, just like they prevent from getting chickenpox or measles, prevents them from getting HPV. If you can prevent them from getting HPV, you can prevent cervical cancer. So 99% of the time, if your patient has cervical cancer, they have been infected with HPV, the human papillomavirus. So how do you know somebody has cervical cancer? Well, the early cervical cancer is very hard to detect, which is why in healthcare we strongly recommend that women get their yearly pap smear. Because when a woman goes in and gets a pap smear, they get these cells off of the cervix, and that's where they can tell if those cells are abnormal and if they're converting into cervical cancer. Now, the HPV virus can lay dormant for years, which is why we still recommend women up into their 50s and 60s still should get a pap smear just to make sure that they haven't gotten infected 20 years ago, lay dormant, now they're getting cervical cancer. If some symptoms are present, they may have some thin, watery vaginal discharge, which again is, might not even be noticed as a symptom. They could have some abnormal bleeding. They might have a little bit of yellow, blood-tinged bowel. Again, pattern here, if your patient is starting to complain of some abnormal vaginal bleeding, they need to get that checked out immediately. They could have some postcoital, this is the word for after sex, pain. So they would have sexual intercourse and then have some discomfort afterwards. Because the tip of the penis kind of bangs on that cervix and can cause it to swell up. And if it's already got some malignancies there, then that can lead to some discomfort afterwards. Bleeding between menstrual periods or really heavy menstrual periods, this is often a late sign. You're going to see some of these later signs in your female patients who don't get routine physical care. They don't have good access to health care, are underserved populations, things like that. So if you're seeing some of these symptoms in your patients who are not getting the kind of care that we would hope they get, could be a late sign. So what do we do about it? First of all, what are the risk factors? The risk factor is anybody who is in a situation where they may have been exposed to the HPV virus, and obviously these are people who have started sexual activity at an early age. So we see this a lot in our younger adolescents, people that have had multiple sexual partners or intercourse with high-risk males. So this becomes a little bit tricky because we like our female patients at the age of 13 to start getting vaccinated for this, because as we know, in healthcare, our adolescents, unfortunately, even against medical advice, are starting to have sexual intercourse a little bit earlier than we would like. So your patients who are having intercourse at the age of 13, 14, 15 are more likely, one, to not understand how to practice safe sex, and unaware of some of these viruses that can lead to some of these malignancies. So here's the other tricky part. So a mom comes in with her 14-year-old daughter, and you're the nurse or the nurse practitioner, you're assessing the child, and you're suggesting that this little 13-year-old get this HPV vaccine. The mom's like, oh no, we're not having that. She's not gonna have sex till, at least she's in college. After she's married, she can start having sex at the age of 32. That's what most mothers are thinking, and this little 14-year-old patient of yours is sitting there, she's already had sex for the last year. So it gets a little bit tricky because she's not going to say that in front of her mother, but you want to protect her so that she doesn't get cervical cancer, so it becomes a little bit tricky. One way to do that is to give the mother some forms to fill out and say, I need to do a physical exam, on your child. Hopefully the mother will or the father will leave the child, and so then you can have a conversation with this child about safe sex, and two, about getting the vaccine. So early detection is super important. So the patient needs to go in and have a pap smear. Now these pictures, if you've never seen a pap smear, this is what they look like. So when you're doing a pap smear on your patient, what they do is they put the patient in lithotomy position, meaning both legs are up. They go in with a scope which will open up the vaginal canal. So it's opening up like this, and right at the end of the vaginal canal is the cervix. This is the cervix. It's got like this little fish eye thing right here. And then what they'll do is, and if you guys end up working as a nurse practitioner, this is a common thing that you'll do. You get a long swab, you swab the cervix, you're getting the cells from that cervix, and then you send that to the lab, and they can identify what kind of cells are on the cervix. This is a normal looking cervix. When there is a carcinoma starting to develop, and when it first starts, it's called carcinoma in situ, meaning it has not really